So our next speaker is Professor Gavin Williams. He is a professor of physiotherapy rehabilitation and jointly appointed between Epworth Healthcare and the University of Melbourne. Professor Williams has a 30-year experience in neurological rehabilitation and is a world leader in the assessment, classification, and treatment of mobility limitations following traumatic brain injury. Gavin was awarded a fellowship to the Australian College of Physiotherapists in 2011 and was involved in the development of a new classification system for Paralympic athletes, which was implemented at the London Paralympics. So please join me in welcoming Professor Williams.
Thanks very much, Dana. Thank you to the organisers and this invitation to speak. So I'll be talking from a clinical perspective and from the point of view of clinicians and patients in regards to what the considerations and practicalities for implementing robot-assisted gait therapy might be in neurorehabilitation, and also from the perspective of robotic-assisted gait therapy being used as a rehabilitative device. So I'm just going to show a couple of quick videos just to demonstrate what's possible in rehab and provide a bit of context for the presentation and what I'll be talking about. So this is a young kid who got run over on the way to school and suffered a very severe traumatic brain injury. And so this is 9 months after his accident. And this is another 9 months later on. So 18 months of rehab, nearly daily intervention to get to this point. This is another one of our young adults who triathlete knocked off his bike and also suffered a severe traumatic brain injury. So this is 8 months after his accident when he's first starting to walk independently. And then after, just over 2.5 years, he's also back running. And then finally, as Thomas Love said in the introduction, physiotherapy is often, requiring 2 or 3 therapists to get someone on their feet and walking. And so this young man is, still requiring a lot of assistance to walk 3 months after his brain injury. But again, by the 9-month mark, he's made, quite considerable improvement. So, as I said, I was just using these videos to provide a bit of context to the presentation and what might be possible. But rehab really is about the restitution of function. And the 2 primary ways in which this can be achieved is via true neurological recovery, so getting back to normal and normal brain function, or possibly and probably more commonly via the use of compensation strategies. But patients want recovery. They want to get back to what they understand as normal, but they also want to function. So, it may well be that at some point we need to teach compensation strategies, as a secondary or a backup strategy. And I think we need to discuss where in the rehab process robotic-assisted gait therapy is best positioned, but I'll come back to this point. So, in 2009, Tyson and Connell talked about this concept of clinical utility, but they conceptualize it in relation to the clinical use of outcome measures in rehab. But the same can be done in relation to our application of interventions. So they propose 4 key criteria for implementing things into clinical practice. Firstly, time. So time to put on and off, in this case, robotic-assisted devices. Treatment time is very valuable. Patients don't get enough access to, therapy time in hospitals, so we can't waste it. Also time in the sense of getting familiar with a robotic device and the familiarization phase, as opposed to, the following phase where the robotic device actually provides some a training stimulus that the patient may well benefit from. And then also time in the context of the rehab phase. So what phase of rehab should we be implementing robotic-assisted devices? So, I'd suggest in the subacute rehab phase. And so from those videos, those 3 people had all had sustained severe traumatic brain injuries. And we know the subacute rehab phase for stroke, for example, is much shorter. than what it is in brain injury, but we also know that the hospital lengths of stay are much shorter again. The second concept they proposed was cost. So we know robotic devices at this point in time are very, very expensive. And if we are going to implement them into rehab, well, who's going to bear the cost? If you think about the organisations, public hospitals, probably don't have the funds. Private hospitals probably, similar as that in that regard. But I do know some that use it, primarily as a marketing tool. The patients can't afford it, and most funding bodies I'm aware of, wouldn't consider it given the lack of evidence for robotic assisted gait therapy at this point in time as a rehab device. We also need to think about cost in terms of the cost benefit for the patients. So patients are always evaluating the perceived benefit for any given intervention, okay? And not just in terms of money, but in terms of the effort and fatigue. So many of our neurological patients get prescribed, simple orthotic devices like AFOs, and they're simply not used. It might be because they've only got use of one arm and they can't put them on. It could be because they're too bulky or awkward to wear, or they don't provide sufficient benefit towards their walking or their function, given the effort required to put them on and off. And we do really need to consider many of our patients who only have use of one arm, because as much as possible, robotic assisted gait therapy may well be a device that could free up the use of the arms, because so many people need to use their arms to walk, and it may be an option to free up their arms, to do what they, should be doing while we're walking around. The third concept was around specialist equipment and training. So clearly, robot assisted gait therapy is very, very specialist, and it's not just the cost of the equipment, but the training and knowledge of the staff in order to, apply it and implement it, particularly considering, staff turnover. The other thing from a specialist perspective is that, the people who are most likely to benefit from robot-assisted gait therapy are in the subacute phase, and they're in or outpatient rehabilitation, and that's also where most of the specialist knowledge is. And so beyond this phase, people tend to be managed in community-based settings by community-based providers who do not necessarily have the required knowledge and skill, to apply devices such as this. And then finally, the fourth thing was portability, and so most robot assisted gait devices at this point in time mostly used, in the centre-based setting, and not so much in the community. And in some countries, the US, for example, there are licensing issues for their use outside clinical settings. Other things that are probably important to consider in terms of the clinical utility and the practicalities of using these in clinical settings is up until now, the most common application for robot-assisted gait therapy has really been spinal cord injury. And in terms of spinal cord injury, these devices are often definitive. And unfortunately for the patients, they really have no other choice or option to walk other than robot-assisted gait therapy. So it does give them an opportunity to walk that is otherwise impossible. But many, many people in neurological rehab will walk to some extent. And so the question, if we're going to use robot-assisted gait therapy as a training tool, is will it achieve better walking outcomes or mobility outcomes for patients, or will it achieve similar outcomes but much more quickly if it's actually used as a training tool? Other important considerations of fatigue. So fatigue is a major barrier to us implementing the rehab that we need to do following stroke, brain injury, MS, many, many neurological conditions. Fatigue is the #1 reported symptom. So this is not simply a barrier to the application of robot-assisted therapy, but rehab in general. Other things that might need to be considered specific to different populations, just something basic like skin integrity. If you consider the average age of someone having a stroke is over 70, they often have altered sensation, often have poor skin and poor circulation. So we need to be, careful and mindful of anything we apply to the body and what its potential problems might be. And then applicability. So we really don't know at this point, you know, the who, what, when, why, how much of robotic assisted therapy we can use, particularly if we're thinking about it as a rehab tool, a rehab device, as opposed to a definitive tool. When we think about who robotic assisted gait therapy can be applied to, Hertz published this paper on how common are the common neurological disorders back in 2007. So we know, you know, some of these common neurological disorders, but the most common neurological conditions that are classed as neurological disorders actually don't usually have gait impairment. So they're epilepsy, migraine, Alzheimer's, things like that. But of those that do, so stroke, brain injury, often cerebral palsy, they tend to have a unilateral or a hemiparetic presentation. So in terms of applicability, those hemi-presentations, particularly in the subacute phase, robot-assisted gait therapy is probably most likely to be used as a training device, and it might need to be used unilaterally rather than bilaterally. Whereas spinal cord injury, maybe MS and some other conditions, it would most likely be used bilaterally and possibly more likely as a definitive tool. So I think we need to think about, you know, who and how. This is a table from Simone Dorsch's paper in 2016 about paresis following stroke. And obviously, there's a very good rationale for robot-assisted gait therapy in stroke. So we know stroke is very prevalent, a hemiparetic presentation is most common, and gait limitations are very common after stroke. But we also know that there is recovery to some extent, can be expected. So robot-assisted gait therapy is potentially a great implementation and device that needs careful consideration. And the huge motivation for robotic-assisted therapy, if it works, is for function. Okay, so independent walking is the primary goal of patients and clinicians working in neurological rehab. So those four references there have looked at what are the primary goals for patients and clinicians in neurological rehab. So that's the primary goal, is mobility. So that's where it can most likely be used. But the patients also want to walk normally. And so from the patient's perspective, some of them will do anything, try anything, in order to walk, and many love the tech, but also many don't. You know, some people won't even wear a simple AFO, even as an interim measure, because they, feel that it might compromise their outcome because they might become more dependent on it. So there is, potentially a barrier there that we need to address when we're implementing, technology such as robot-assisted gait therapy. And while we're talking about perception, the other thing we need to consider is many of our patients have perceptual problems. So whether that's their perception of vertical, so they might have pusher syndrome, or a neglect or hemionopia, these things are also, common enough that they may be a barrier, or that we need to consider, who are most likely to benefit from this type of therapy. In terms of applicability for function, in terms of applicability for function, robot-assisted gait therapy as a training tool needs to be responsive. So, it needs to be a system that's designed to work within a funnel, or that Thomas Loves talks about, so that training device is responsive to the patient's own muscle activity. Otherwise, it's just simply a passive or controlling device, and that's not really rehabilitative. So for those with no or very limited capacity for recovery, they may need a definitive device in order to walk. And I think it's important that we are clear on the application and the function for the patient, and whether we're actually using these devices as a rehabilitative tool or as a definitive prescription for the patients. So in terms of walking, and Marcus has very, very eloquently shown, we know a lot about normal walking. So we know the range of motion people go through, where the power comes that is required for forward propulsion when we walk. And we know that most of the power for forward propulsion, comes from the ankle plantar flexors, hip extensors, and hip flexors. The other thing we need to consider is that even though we know a lot about normal, very, very few of our patients walk at a normal speed. Okay, so most of the patients start in rehab following their brain surgery, stroke, brain injury, exacerbation of MS, start as physiological walkers or non-functional walkers, as Perry would describe them back in 1995. And so as people go from being very impaired with their walking and improve their walking to, so from very slow to back to a normal walking speed, the range at which the joints move through greatly changes, maybe up to a factor of 3 at the ankle. And then the other thing that changes is not just the joints, but the range that the joints go through, but how quickly they move through that range. So we can't just use our knowledge of normal biomechanics obtained from normal walking speeds when we apply robotic assisted gait training, because most of our patients are much slower, and then hopefully the robotic devices can dose these features as the patient recovers. And the changes that we see at the joints and the limb are not uniform, they're quite specific. So angular velocity at the ankle, is reasonably unchanged in mid-stance across a whole range of speeds, and reasonably unchanged in swing phase. But there's a massive change in terminal stance for as we plantar flex for push-off. And so, the ankle might be moving 3 times faster as someone improves their walking speed in their recovery phase, and robotic devices, may need to not only allow this, but actually drive it. Okay, so we need to progress speed in order to progress function, and robotic devices need to be developed with this in mind. They have to facilitate this and even drive it, and not just control or contain or hold back the person's recovery, but the patients may change quickly in a subacute phase over weeks and months, and in terms of their motor recovery, the robotic device really needs to accommodate this, if not actually drive it. So, as I've said it, just to reiterate, it's well established that the primary goals of people in rehab are about independent walking, okay? And not only that, but to be able to walk quickly. And we know that many of their patients compensate when they're walking, they lift their leg instead of pushing off the swing phase. But for most, the initial goal is to try and achieve some level of normality. And so when we're looking at robotic devices on the left there, or like the C-brace in the middle and on the right here, these assistive devices can be very onerous. Okay, they might enable people who can't walk to walk, but we must remember they're onerous, they're high energy costs, they're slow, they're not necessarily functional. You might not be able to use your arms if you for anything else if you need them to assist your walking, and so we're still at a stage where patients like this still use their wheelchairs around the house, because they need to use their arms to walk. And so around the house, around the kitchen, they still use wheelchairs, because that way at least they can transport things with their arms, rest things in their lap. So another key challenge, I think, will be if we can design robotic assisted devices that can potentially give the patients their arms back for their mobility. And so who should we target? So I think this is a theoretical relationship between strength and mobility following stroke. Okay, and so they propose that there's 3 zones. So zone C are those people who are basically too weak to walk. You can see the relationship between strength and speed is not uniform. And so robotic assisted gait therapy has largely been focused on zone Cs, people who don't have the strength to walk. And for those who don't progress from zone C to zone B, robotic assisted gait therapy may well be, that might be a definitive prescription for those people. In zone C though, this is where strength training trials have largely targeted. So the 2 things that pretty much determine someone's outcome from a mobility perspective is how strong they can get and their task practice. So strength training and task practice. So that's where robot-assisted gait training comes in. So this is where the relationship's most strongest. And there's been literally dozens of RCTs that are focused in this zone B, and using strength training to improve mobility. So I'd suggest that if we're applying robotic devices in zone B, then they would be a real rehabilitative implementation rather than a definitive prescription for someone. And then zone A, so those people who still might have some mobility limitations, but these are people who would be ambulance in the community. They still might have goals to improve their ability to go up and down stairs or run or get, return to work or social leisure sporting activities. Now, I'm not sure the extent to which robot-assisted gait therapy would have for people here. So I think probably zone B and zone C is where it's at, but zone B would be as a rehabilitative intervention, whereas zone C might be a definitive prescription. So just last slide in summary. For many of our people with neurological conditions, paresis is the key impairment. Up to 80% of people with stroke, for example, have problems with muscle weakness. And because hemiparesis is so common as a clinical presentation, it sort of suggests that there is a real need for a unilateral robot-assisted gait device. Rehabilitation needs these devices, but they need to be bespoke. They need to be able to optimize people's outcomes, but given how much variability there is within our patient presentations, they need to be adaptable, to the range and severity of the clinical presentations that we are dealing with from day to day. So hopefully they don't aren't just simply definitive prescriptions, but they in rehab they can assist in us driving recovery if the application is rehabilitative. It has to have a cost-benefit analysis, and I'm not just talking about the cost of the machines and units themselves, but the cost to the patient, the time, the effort, the fatigue. It has to be better than usual care in what they're currently receiving. And then finally, this is a field, I think, that is just perfectly positioned for co-design. I think devices need to be co-designed with clinicians and patients in particular to have a really good understanding of what is practical and feasible, given all the potential barriers for our people with neurological conditions. Thank you.
Tomislav, we're not able to hear you.
We can't hear you, Tomislav.
Do you hear me now?
Yeah, we got you.
Okay. Thank you, Gavin, for this very insightful talk. It's always good to hear the therapist side as well. Are there any questions here in the room or online? So I just have one question then, in the interest of time. So you said that the restitution function is the most important, and this is generally the best done in a subacute phase, the early stage. But this is also the phase when time when patients cannot necessarily actively participate. And you also mentioned that active participation is important. So how do you like approach this, right? Because you want them to actually learn, they need to actively participate, but the time when that's most likely possible, they cannot really participate as much as you would like them to. Does that make sense?
Yeah, so it varies enormously, and different people have different amounts of fatigue and issues like that are a barrier to their rehab. But it's some of these issues with fatigue, for example, can be lifelong for many of our patients. But it's certainly a feature in the subacute phase. But regardless, the subacute phase is the period of time that patients are most likely to benefit. And that may be also a reflection of the studies and the way the studies have done, and that and funding models for how long people can be in hospital and how intense their rehab can be. And it may well be that people can benefit for a longer period of time than what's been shown to date. But it's certainly it's a balancing act, day to day in how much therapy we can provide and how much the person can tolerate.
Okay, thank you. Okay, so we can then move to the next speaker, which is me. But let's thank Gavin for his. Thank you, Gavin.